Welcome to this evening's webinar on demystifying bladder cancer surgeries and also learning how pelvic floor physiotherapy can help manage some of the postoperative complications. I'd like to extend a big thanks to Alex Huang for organizing this event this evening. And it's always a pleasure to be able to share some of the knowledge that I've acquired over my professional career with those who would benefit from receiving it. This evening's workshop, or sorry, not workshop, but seminar, will run for approximately 50 minutes or so. And we will have a period where we'll get up and take an active break. And then the topics that we're going to be covering this evening include how pelvic floor physiotherapy can help with the postoperative complications, and also learning a little bit about what pelvic floor physiotherapy is, because most people really don't have any clue about it, or perhaps have never even heard about it. The other topic we're going to discuss is the types of bladder cancer surgeries and which one might be best for you. And then we're going to finish up learning an evidence-based exercise protocol for the management of bladder leakage and various other postoperative complications. So a little bit about myself. My name is Christina Dzieduszycki, and I'm a registered pelvic floor physiotherapist. I work with men, women, and children who suffer from pelvic floor dysfunction. And pelvic floor dysfunction is really just an umbrella term that encompasses a myriad of conditions, including bedwetting, bladder leakage, constipation, erectile dysfunction, painful sex, prolapse, urgency and frequency of urination, and many more. However, for the purpose of this presentation, we're going to be focusing primarily on bladder leakage, somewhat on constipation, and we're going to touch a little bit on erectile dysfunction. I decided to specialize in men's health primarily because of the opportunities that were presented to me throughout my professional career to work with some of the leading urologists across the greater Hamilton area. After spending days with them in clinic and having been privileged enough to witness and observe some of these surgical procedures being done, I was able to take that knowledge that I had learned from them and develop an understanding that, you know, as I was seeing more and more of these patients, I started to realize, like, wow, there's really a need for healthcare beyond just what's offered in the medical system. And, you know, I really wanted to start raising awareness about the need for this, because the reality is that men's health lags behind that of women's health by approximately 30 to 40 years. So there's really a tremendous need for people to specialize in this area. And so with that, I decided to embark upon research, and I applied for my PhD. And I am also in the middle of completing an applied clinical research program to better prepare for that PhD, because there is a lot to learn about when you're embarking upon research. So yeah, so that's kind of what I'm doing right now with McMaster University. And I also have, I am the owner and founder of New Life Physiotherapy. We are located in Ancaster. Fortunately for the COVID, we now are providing virtual capacities for assessments and treatments. So that is something that we offer to those who can't necessarily take part in the travels. Okay, so without further ado, let's begin. So did you know that in 2021, 12,200 Canadians will be diagnosed with bladder cancer? 2,600 Canadians will die from bladder cancer, and men are 3 times more likely to be diagnosed than women. It is the 4th most common cancer in men, and 90% of the cases will occur in those over the age of 55. Smokers are 3 times more likely to develop cancer and the bladder cancer, and that is because of the carcinogens found in the cigarette. That basically, if you have a look here in this image, you've got the bladder that's essentially blown up, and now you can see the lining of the bladder and the cells that make up the inner lining of the bladder. And these cells, with chronic exposure to carcinogens, they start to change and they start to morph, and then they start to grow tumors. And so that's a really big risk factor for those who are smoking. The other really interesting thing is urinary incontinence following NeoBladder surgery, which we'll talk about in just a moment, is very common and rarely, if at all, referred to pelvic floor physiotherapy. Which is kind of frustrating, because what we know is that pelvic floor physiotherapy can accelerate the return to continence by almost 50% faster than none at all. And so I'm here to explain to you why on earth you would come and see a physiotherapist to manage incontinence, because we don't typically think of going to see a physiotherapist to help with leakage. We think of going to see a physiotherapist because you maybe have a muscle injury, or perhaps you're going in for surgery and the surgeon says, okay, we'll go and strengthen these muscles and these tissues before the surgery, and your post-operative recovery will be much better. And so unfortunately, these individuals are also going through surgical procedures, but that is not part of common healthcare practice today. These individuals are not really well informed. And so what happens is that the pelvic floor is made up of muscles. And most people don't even know what the pelvic floor is and what it's made of. And so I'm here to explain to you that seeing a physiotherapist is your best bet, because we are specialists in restoring the strength of muscles. And here's an example. There's the pelvis. And so this image, I'm just trying to orient you a little bit here. And although this is a female model, I want you to imagine that same thing holds true, except here, if I just bring my cursor into the male model, this would just be that muscle covering up this hole here, okay? But the rest all holds true and similar. So these muscles have various functions in the human body. And in particular, there's 5 main functions. So one of the main functions is sexual function. If we look here at the outer layer, these are really in the male population, the roots that create the penis, okay? So these muscles here basically extend and create 3 chambers, 2 top chambers, and then 1 bottom chamber that houses the urethra. The same holds true in the female population, okay? Except the urethra is obviously not extending out. Now, the second layer, we've got the external urethral sphincter, and that muscle there is basically housed between the pelvic diaphragm, which is inside, and then the muscles of the sexual function on the outside. And it's sandwiched right in the middle, and this is the external urethral sphincter muscle. All these muscles we have voluntary control over. And when you have your bladder removed, in the male population particularly, you also have your prostate removed. And so in doing so, you lose something called an internal sphincter. And so you become 100% reliant on this muscle as well as this muscle to optimize your ability to maintain continence. I want you to really keep these 2 images in mind, because they're going to be coming back quite a bit. And I just want you to appreciate where they're located in the body. The third layer is the innermost layer, and this is called the pelvic diaphragm. Its job is to support and stabilize the pelvis. So the internal organs that are located inside, you've got the bladder, that's just located just behind the pubic bone here. And then you've got the rectum that lives just behind in the back. Okay, and it's all very sandwiched into this area here. This is a female model, so in the female model, you would naturally have the uterus as well, sitting here. Okay, so these muscles, they tend, because they're all wired together, they tend to fire together. However, when trying to maintain continence, we think about pelvic positioning, and that's something that we're going to touch on in the Unit 1 workshop. Because if you position your pelvis in the appropriate manner, you can actually isolate the front 2 muscles here. So the one located under the testicles, and this guy right here around the urethra. And the same holds true for women. If you position your pelvis in the proper position, then you're more able to recruit the appropriate muscles. So here's an animation so that you can better understand the mechanics. And technique really, really matters, particularly in the male population. So with this scenario here, we've got the bladder, we have the prostate, okay? Then we've got that striated urethral sphincter here, and then the bulbocavernosus. So within the prostate, there used to be a muscular gland that was under involuntary control. So the brain would take control. When the bladder filled, the signals would be sent up to the brain, would say, hey, brain, we're full. The brain says, okay, and then it squeezes down on the prostate here, and it blocks off any loss of urine. But when you lose the bladder and the prostate, you're now left with this striated urethral sphincter. And fortunately, it's under our voluntary control. So we can train that muscle to become stronger and have better endurance. So I'm just going to go back. So again, this striated urethral sphincter and this bulbocavernosus muscle are here and here. This muscle I want to draw your attention to is called the puborectalis muscle. That is the muscle that comes from the pubic bone here in the front and that wraps around the rectum through the back, okay? And it goes around like a sling. Now, if once this structure and this structure are removed and the new bladder is repositioned here, it's actually going to no longer sit up where it initially did or originally did. It's going to now sit behind this puborectalis muscle. So if you employ strategies that request you to prevent the passing of gas, then you're going to be recruiting this muscle. And if you're not properly positioned, you're going to be recruiting this muscle, which then, if you think about it, if this new bladder is located behind that muscle, what happens if that muscle squeezes on that bladder? You're going to have leakage. So it's really important to make sure that we learn how to isolate these top or front muscles so that they can more effectively close down on the urethra. You'll also notice that the greatest curvature in the urethra is located here in the front. And if you were trying to prevent water from coming out of a hose, you wouldn't just grab the hose like that. You would actually kink the hose in half, and that would prevent leakage or urine from escaping or water from escaping. So the same thing holds true in this scenario here. We do the same. We kink it by recruiting these two front muscles. So I want you to really have this image in your mind and understand how important technique really is. So that's the continence piece. And as I mentioned, we're going to go over that in our Unit 1 workshop. And we're going to learn exactly how to recruit these muscles. However, there's the opposite side of things now in this population where voiding becomes quite different. And here the patient needs to learn how to relax the external urethral sphincter, again, this muscle right here, while increasing abdominal pressure, okay? Because the new bladder is not a muscle anymore, and it doesn't have the ability to contract and empty its contents. So the person becomes reliant on the abdominal muscles outside to create that pressure to help eliminate. Now, this is not as easy as it looks or sounds, or maybe it doesn't sound easy at all. But relaxing that external sphincter while simultaneously creating pressure from the abdominal cavity is quite a feat, and it does require some coaching. So that's where pelvic floor physiotherapy can really assist in these situations. I also forgot to mention that if you have any questions or there was something that you wanted clarified, because I understand that some of this can be quite detailed and involved, please feel free to leave your comments in the chat, and then I will answer them at the end of the workshop or of the seminar. Okay, so bladder cancer surgeries. There are typically 3 types. And the first type, we call it a non-continent diversion, so the ileoconduit. And that's because what happens is there's going to be a piece of intestinal tissue that gets reattached to the ureters, which are the tubes that allow for the kidneys to eliminate the urine. And then this segment of intestinal tissue will then come out to the front of the body, and what you have is something called a stoma. So you'll then place a urostomy or a bag that will surround it to allow for collection of urine as it comes out. So this type of surgery is very seldom referred to PT because you don't really need, and PT being physiotherapy, because you don't really need to use your pelvic floor to manage this particular scenario, right? It goes into the bag, you take the bag off, you empty the bag, and then you put a new one on. So, but my debate or my way of looking at it is, what about the abdominal weakness that comes from this particular type of surgery? What about the increased risk for hernia that these patients are at risk for? So all of those things need to be considered, and certainly valuable to see a physiotherapist to manage that. And we'll touch on that in just a moment. And you'll have some pictures of the scarring that actually is involved in these procedures. The other type is the Indiana pouch. And we call that the continent diversion because here there's going to be a pouch located inside the body as opposed to a bag located outside of the body. This typically is what we'll see more often in females. And that has to do with the urethral length. Okay, this seems to be a safer approach for women. And what happens again, intestinal tissue, they basically create a pouch from that tissue, they reattach the same way, and now the stoma is still coming out to the surface of the skin. The only difference here is that you put a catheter in and you empty out the pouch, every couple of hours, because you don't want the pouch to overstretch either. So there's a very specific timeline with which you have to empty the pouch. And then that's basically how they continue to live their lives, is with this continent diversion. Then there's also the orthotopic NeoBladder. This is also called the heart-shaped NeoBladder, but we're going to touch that in just a moment. So this is the one that's most commonly referred to PT, because this particular type gets reattached to the urethra, and these individuals really need to learn how to use their pelvic floor muscles, the ones that I showed you at the beginning. They will become 100% reliant on that external urethral sphincter as well as that vulvocavernosus muscle to effectively close down on the urethra and prevent any leakage. Same situation holds true. Intestinal tissue creates the pouch, and the kidneys, the ureters, are reattached to that pouch. Now, the interesting thing with this particular scenario, and I would argue the same would hold true for the Indiana pouch, is that initially it's not going to hold a great deal because the intestinal tissue has to stretch over time. But as you follow a time-voiding guideline, you will get the NeoBladder to hold roughly about 400 to 600 cc's. And that will allow you to have roughly about a 3 to 4 hour window where you can hold and not have to go urinate. Because initially you'll see that you'll have to make frequent washroom trips to prevent leakage, but also to allow for gradual stretching of the NeoBladder. So with regards to these three different types of surgeries, which one would be preferable, or which one is best for you? And it boils down to these few topics or bullets here. So the surgeon's skill is really a big piece here, because if so many of the surgeons are not trained in how to do NeoBladders, and so they're more comfortable doing the ileoconduit or the Indiana pouch. Truly, the NeoBladder surgery is nothing shy of a miracle. I couldn't believe it when I was watching Dr. Shagan performing this surgical procedure. It was absolutely fascinating. And so, and there's not many of them out there. And so that's going to be one big decision that you and your surgeon are going to make, and he'll discuss that with you. Or she'll discuss that with you, depending on who's doing it. The other big things to consider are the patient's motivation, the patient's dexterity, their eyesight, and then, as we mentioned, gender. So imagine with the urostomy, if you have arthritic hands, then that's not going to be overly easy for you to have to clean and take off and then, put back on. That's going to get quite challenging. And then likelihood is that you're going to make mistakes and it could be quite messy. Again, if you can't see properly, then naturally there's going to be some concerns there with regards to having the ileoconduit version. So sometimes these are the things that really need to be considered. And that's really what Dr. Shagan had mentioned to me, and that's really what it comes down to. So you'll have a discussion with your surgeon about which approach would be best for you. So as we mentioned earlier, the NeoBladder is really the removal of the the bladder and the prostate. So they call it a cystoprostatectomy. And this turquoise area here demonstrates or highlights the area that's actually being removed. In addition to this, there's the removal of lymph nodes. And in this patient population, there could be quite extensive removal of the lymph nodes. That could lead to something called lymphedema, and we will touch on that in just a moment. In fact, we're going to learn how to move to facilitate the lymphatic system and help circulate fluids through the system. And we're going to touch on that in a few slides. The other thing that happens is they try to spare as many nerves as possible for two reasons. One, to enhance your continence mechanism, but the other one is to preserve erectile function. And again, we will touch on erectile function at the end of the presentation today. Okay, so the modified stutter pouch is basically what you see here. So they take a piece of intestinal tissue from the small intestine, they cut it out, and then they basically put it on a surgical table where they fillet it, they cut it all open, and then they resuture it together to create this pouch that you see here. And in doing so, they pull on the ureters and they reattach the ureters to the appropriate location. And now the issue with this one that Dr. Shagan told me is that what happens is that there's this tugging or this pulling on the ureters, and that pulling creates a hypoxic scenario in the ureters, which means that it gets deprived of oxygen. In doing so, it's going to damage its function, potentially, not always, but potentially. And then this puts the patient at risk for having strictures developing in the area. So you can start getting some blockage, which, as you can imagine, is going to result in a medical emergency. So what they do now, or what some surgeons do, and I was able to witness, is the heart-shaped bladder. And this is what Dr. Shagan did. He did everything inside. Nothing came out. It was truly fascinating to watch. This surgeon is just remarkable. I can't say enough good things about him. But so again, the same kind of approach is applied, where they'll fillet this area here and then recreate the pouch internally. They don't disrupt the ureters. They get reattached right there, and that's it. Now, one thing I am going to say, pre-op, okay? Nobody tells you this in school. I certainly didn't learn this anywhere in a manual. I was very fortunate to learn this by observing what I saw in the surgical room. Bowel prep. The particular individual that I saw maybe didn't do an overly good job at bowel prep. And so when you cut open the small intestine, what's inside of the intestines? Stool. And so if you do not make sure that you're diligent with your bowel prep prior to the surgery, you're going to have a situation of perhaps stools floating around inside of your body, which stools are full of bacteria, and it's just something that you probably don't want to have. So I am going to highly recommend that if you are going with this surgical procedure, be sure to be diligent with your bowel prep. Okay, so some of the post-surgical side effects include post-op scarring, like we had mentioned. So the ileoconduit version here is this image here. You can see the scar that runs pretty much from the belly button just above the pubic bone. That's the stoma that we were referring to. Okay, and then in this one here, you've got the orthotopic NeoBladder. So this again is done open. Okay, this is not done robotically like the one that I was able to witness. Again, same idea here. The scar is still rather significant. So there's going to be a considerable amount of abdominal weakening. And remember, with this population here, if they have this NeoBladder in, they need their abdominal muscles to void effectively. Remember, I mentioned that, right? So it's really important to consider more than just the pelvic floor in this scenario. Now here we've got the robotic-assisted laparoscopic cystoprostatectomy. And this scenario here, yes, the scars are significantly less. And even less so if they don't actually do the stutter. This is a picture of the stutter pouch where they removed it and they had to take it outside of the body, where with the heart-shaped one, the incision is literally where there's no scarring in this individual. It is so tiny. And then you've got just the 6 little punctures where the arms of the robot go in so that the surgeon can do their surgical procedures at a remote site in a viewing site. So although there's minimal scarring in this scenario, there's still a lot of punctures going on. And anytime you've got trauma within this abdominal cavity through surgical procedures, then it's going to start compromising the various muscles that make up the inner core. And that's something that we're going to touch on in just a moment. All right, so that inner core is made up of the diaphragm above. It's made up of this massive corset-looking muscle, and then the pelvic floor and the multifidus. So these 4 muscles all work together like a team, okay, to optimize the function of the pelvic floor. So if any one of these, they're almost like gears on a bike. If a gear doesn't work or it doesn't turn, well, the next one's not going to work very well either, right? And all of these muscles work in a coordinated fashion to provide optimal functioning of the pelvic floor. Okay, but what happens when we have surgical procedures done in the abdominal area particularly, the diaphragm no longer moves through its full excursion. And I'm not sure if anybody's aware, but the diaphragm, this picture doesn't really do it justice, but it comes from the breastbone and it travels underneath the ribs all the way around to the back. Okay, and it sits up domed inside of the rib cage when we've exhaled. But when we inhale, it drops all the way down and it has quite a bit of movement. It goes from here all the way down to here. So that's a lot of movement. But what happens when you have all this trauma to this area? That diaphragm just stays here and it doesn't really move much. So you're not going to get oxygenation to the bases of the lungs. You're going to have delayed healing because of poor breathing mechanics. And so learning how to restore the function of the diaphragm is extremely important. It's always the first thing that we consider post-operatively to accelerate healing, but also to make sure that if it's needed in this situation, that the pelvic floor is working as well as it can as well as it can. So think about the diaphragm above and the pelvic floor at the bottom is like a bowl, and this is the upside down bowl. So when the diaphragm contracts, it descends, and the exact opposite happens is that the pelvic floor lengthens. So it's like a piston that works together. But if your diaphragm isn't moving, then neither is your pelvic floor. It's just staying tight and it only knows one range of motion. So imagine you only ever trained your biceps here and you never did a full bicep curl. What would happen if all of a sudden you had more pressure on your arm and the bicep went out a little further? It wouldn't have any strength. So you've got to make sure that that whole system is working properly so that you can get full range of motion out of the pelvic floor and train it through its full and entire range of motion. I hope that makes sense. I know it's a lot, and we are going to go over the inner core in more detail in that pelvic floor fitness workshop on May 11th. Okay. I've also mentioned that those who've had surgical scars in the stomach are more at risk for incisional hernias. So that is something that needs to be worked on. We need to work on the scar tissue. Scar tissue has this propensity to tighten over time. When it first settles itself out, it kind of just spreads out like a big spider web, all disorganized, and it attaches onto whatever is around. It doesn't know, it doesn't decipher between tissues. It just knows I have to glue onto something so that I can bring those two pieces together to make sure that they stay together. But over time, it just tightens and tightens and tightens if it's left unaddressed. But fortunately, if we massage it, if we stretch it out, if we use our muscles, then that tissue starts to get remodeled and it'll start to realign itself along the lines of stress. So that's the good thing about scar tissue. However, scar tissue is permanent, which means you have to keep at it, these exercises, you have to keep at the massage, you have to keep at the stretching, as well as the muscular conditioning. Okay. If you have something like what you see in this image here called a diastasis rectus abdominis, which is a separation in the abdominal wall, that can also increase your risk for hernia. And it certainly weakens the abdominal cavity, particularly this inner core that I've highlighted here. Okay, so the six-pack muscle is not the one that's damaged. It's actually still very well connected to its sternum and then to its pubic bone. The one that's damaged is this big guy here. Okay, and in women, we see this typically in the third trimester of all pregnancies, but then when the baby comes out, the stomach muscle typically comes back together, and if it doesn't, then we coach the woman on how to get those muscles strong again. In men, however, we often see them with large waist circumferences for sometimes decades, and it's difficult because if you don't lose the weight, then those two pieces aren't just going to come back together. So when the surgeon tells you that it would be a huge benefit for you to lose some weight prior to the surgery, it would also be a huge benefit for you to keep that weight off, okay? And so that you have a better chance at strengthening that core. Okay, so we know now that with the orthotopic NeoBladder, there's going to be some urinary dysfunction. But one thing that is different from our prostate cancer patients is that the incontinence is actually more difficult to resolve at night. And that has to do with the pelvic floor muscles being postural muscles. So they are on when you're standing, sitting, walking around, doing stuff. But the moment you lie, they go to sleep. And then you've got this new bladder that doesn't have any resilience to it because it's just made of intestinal tissue. It doesn't have that muscular wall. And anytime you add pressure onto it, let's say you roll onto your stomach or you're in the fetal position, then that could cause pressure and that could cause that leaking to come out. So that's why it's very difficult to restore incontinence at night. Not impossible, but it does take a little bit longer and it takes a lot of training, because if this striated urethral muscle here gets bigger and stronger, then it's going to better close down on the urethra, and then you'll have better success with managing nighttime incontinence. So beyond changing your sleeping postures, right, from avoiding that prone lying to side lying, a body pillow is useful. So you can use that, and that offloads some of the pressure that the leg crossing over the body creates. Also, obviously, lying on your back is a great solution. But behavioral modifications, so stopping fluid intake 2 hours before bed helps reduce the amount of fluid or urine that the kidneys produce. Also, setting an alarm after 4 hours of sleep is going to be extremely important, because then you'll be able to empty that bladder, and it's also not going to allow you to overstretch the bladder. And this way you'll wake up less wet as well, because you will have emptied that bladder. And then there's also something called desmopressin, which is a medication that your doctor could refer or could prescribe to you if you are really struggling with nighttime incontinence. And basically what it is, it's an antidiuretic hormone. So antidiuretic hormone is more prevalent at night when we're sleeping, because it stops the kidneys from producing urine. And as we age, that antidiuretic hormone starts to disappear. And that's why as we age, we start noticing maybe we're getting up, in healthy scenarios, that we're getting up maybe more than we used to at night to pee. And that's because of the absence of this hormone. So this medication brings that hormone back and reduces the amount of urine that's being created. So those are some management tips that you can utilize if you're struggling with the nighttime incontinence. Then there's the other side. There's the hypercontinence, and this happens in about 10% of men, and they'll have an inability to empty urine from their neobladder. There are different reasons or beliefs as to why this happens. They believe that a longer urethral length might leave some smooth muscle left on that urethra, which means the smooth muscle is what was housed in the prostate, and sometimes it extends beyond the prostate slightly. So the brain will, through the trauma, just contract on that muscle, and it'll just keep it closed, and we don't have control over it. So it just kind of keeps that urethra pinned, basically, or compressed. The other one is the urethral kinking that could happen from the neobladder. So when Dr. Shagan was reconnecting the bladder to the urethra, he had mentioned to me that they don't want to leave too long of intestinal tissue, because that is flimsy tissue. It doesn't have the resilience, right? It doesn't have that muscular wall in it. So there has to be a very specific length that's left. Otherwise, what happens is it kinks, and then that will eliminate or basically make it very difficult for that neobladder to empty. And in those scenarios, self-catheterization is often required. We touched on the time voiding guidelines a little bit earlier, and initially what happens is you'll have to urinate every 2 hours. You'll maintain this schedule for 1 week, and then you'll increase that by 15 to 30-minute increments until you reach that time span where you can go 3 to 4 hours without voiding. And remember, this has to be done all day, all night, right? You're not going to have the sensation to urinate anymore. That the muscle that gives you that sensation in the bladder, the detrusor muscle, is no longer there. So you've really got to make sure you're setting those alarms until it becomes a habit, until it just becomes your new way of living. And the big thing is you don't want to let that bladder overstretch, because then you put yourself at risk for infection. Okay, and you definitely won't be able to void or empty the contents. Okay, so we talked about how important it is to be able to use those external muscles to assist with voiding. And there are other strategies here that you can employ to help eliminate the urine found in the neobladder. First, you start with that breath. So that deep belly breath, that diaphragmatic breath, expands everything. It opens up the area. It helps those pelvic floor muscles relax. Remember, we mentioned when you inhale, the diaphragm descends and the pelvic floor muscles lengthen, right? It's like a piston. So a deep inhalation will allow that expansion or extension or lengthening of the pelvic floor muscles. And then you exhale using your external oblique muscles while keeping the pelvic floor muscles relaxed. To help facilitate that, you can use something called a Squatty Potty. And the Squatty Potty, anytime your knees are above your hips, it actually relaxes the pelvic floor muscles. There was a time before toilets when we would have to void in the squat position. And there's a reason for that, because it opens up the pelvic floor muscles and it allows for effective voiding. Nowadays, we have toilet seats that get higher and higher if people can't get down. And so that creates a scenario that's less than favorable, particularly in this population. Another strategy is called the Crede maneuver. Here, what you would do is you would do the exact same thing that I just discussed. The only difference there is you would just apply pressure above. You'll find the pubic bone just down here. If you touch your pubic bone, you can feel a hard bone. And then if you just move up slightly, there's going to be some soft tissue there. And so by applying your hands just above that soft tissue area while you're sitting, and you take a deep breath in again, and then as you exhale, you apply an inward force. And that helps the NeoBladder empty its full contents. Again, these are, they sound easy until you try them and realize that there's actually quite a bit of coaching required, and that's where pelvic floor physiotherapy comes in to help. Naturally, I'm sure you have all guessed that if you're taking a piece of intestinal tissue to recreate a bladder, there's going to be some compromised function of the bowels. And ileus is one of the most common causes of prolonged hospital stay, which basically means that the colon, it becomes paralyzed. There's this peristaltic movement that happens in the colon and in the small intestines that basically allow the food to get traveled through or pushed through. And when there's trauma to the intestinal tissue, that stops. And so food doesn't get through, it doesn't move through, and so you get a blockage, and that's basically what happens. So they'll keep you in the hospital to make sure that you pass gas and also have a bowel movement. Almost 50% will experience changes in bowel habits at 1 year follow-up, and many of the common symptoms you can see here are bloating, flatulence, which is gas, incomplete defecation, so an inability to fully empty your rectum, bowel irregularity, constipation, incomplete voiding, and then diarrhea. So it can range on a huge spectrum. It's going to be variable from person to person. Not one individual is going to be the same. All right, so constipation management. This will be included in the pelvic floor fitness workshop. And it's to help get the colon moving, because when it's in the scenario that it's in, and it's basically surrounded by scar tissue as well, and the inner core muscles aren't working all that well because the diaphragm's been compromised. If there's an incision in the transverse abdominis muscle, that big corset muscle that I showed you a picture of earlier, then those muscles aren't going to be working very well, and they're extremely important in constipation and just general bowel motility. So when the diaphragm contracts, I'm just going to come here. The diaphragm is located just above, just here, just above this area here. So there's a stomach, and then the diaphragm would come right in through here. Now, when the diaphragm contracts, it actually squishes down on the transverse colon, which is right across this area here. So, and it just squishes down on it. And that action, that diaphragm's ability to come down and squish down on that colon is going to help stools move through. The transverse abdominis, which is that big corset muscle, when it contracts, it works on the ascending colon, which is housed right here, and the descending colon, which is housed on the opposite side. So as you can imagine, you get this kind of coming down sensation here, so massaging the top of the colon, and then you also get this side contraction, right? And so that's extremely important, and those muscles are so important in maintaining proper bowel movements. So the I Love You massage is one type of massage that we teach people how to utilize for home use, because what we're doing is we're helping along those colon lines, we're helping the stools move through. And what happens is you basically, it's called the ILU because you do 10 eyes like so, and you can, work the side, because the colon actually comes up the side of the body. Okay, it's not located right here in the front, it's actually through the side. And so you come through here, you do 10 I's, and then you do 10 L's, and you bring all of that over, right? And then you do 10 U's. And so now you're bringing everything down. You up, over, and down. And the rectum lives on the left side. So I was actually doing that backwards because I was watching myself in the video. But nevertheless, you get the idea. You want to bring it up, ascending colon, over, across, and then down out the rectum. And you just continue to do that 10 times each way until you start to maybe hear some gurgling. And gurgling is a sound, some people think it's a sound of hunger, but actually it's a sound of the cells starting to work in the colon. And so it's a really great sound to hear. Something else that can be done is called connective tissue or skin rolling. And that's basically when you take the skin and you just roll it across. That's all. And what it does is it picks up the tissues underneath. So as opposed to compressing and moving, what you're actually doing is this kind of approach. And so both are really beneficial. The skin rolling can be a little bit painful. And so we try to be gentle with it. But as you get more comfortable with it, you'll notice that you can manage the tissue better. And it's also really, really good for scar tissue management. So the constipation series, as I said, we will go over this one at the workshop. And these are just some images so that you can kind of see how compression of the abdomen will help and how important movement is. The other thing that we do as physios is we refer out to dietitians, because they will be able to help you with perhaps new food sensitivities that you've developed, or maybe you're just not sure how you should be eating anymore because you just can't figure out the proper nutrition plan that's going to manage some of those painful symptoms that having a bowel resection would cause. All right, so we touched on how lymphedema can actually occur in this population, and it happens in roughly about 20% of patients who've had extensive pelvic lymph node dissection. And the reason is, what lymphedema is this kind of unexpected almost swelling or an inability to heal certain injuries that you would otherwise be able to heal. So if you have tissue trauma, let's say you get a sunburn, normally you'd recover quite well from that. Or even if you burnt yourself cooking or baking, usually you'd be able to recover quite well. But in these situations, when you've got lymphedema, it is massive swelling that goes on and really long delayed healing, if any at all. And so it's really important to be mindful of protecting your skin, because you can be at risk for this, but also trying to facilitate the movement of the lymphatic system and what's remaining of it. And there's a very specific protocol here that I would invite everybody at this time to stand up and get out of your seats for a moment, because I know there's a lot of talking. And so what we're going to do is we're going to try this sequence out. We're just going to start feeling how the body starts to warm up, and you're going to start to feel how your circulation starts to improve. So naturally, lo and behold, you start with the breath. How fascinating is that? It always comes back to the diaphragm. So from here, you're just going to take a nice deep belly breath in, and then letting go. Again, deep breath in, letting go. In the Unit 1 workshop, keep breathing for me. We will do a strategy that tests whether you're a shallow breather or a diaphragmatic breather. If you place one hand on your chest and one hand on your stomach and you try to inhale, just pay attention. What hand is moving? Is it the bottom hand or is it the top hand? Which one is rising? And it hopefully should be the bottom one, but 99% of the time it's the top one. So deep breath in. And if you are struggling with this, we'll go over some strategies that you can employ to correct your breathing mechanics. And exhale. Inhale and exhale. Inhale one more time and exhale. Good. Now we're going to do big shoulder rolls. So big shoulder rolls, getting those shoulders right up to the ears. Don't be afraid to move through that full range of motion all the way back. Then you can keep breathing. Don't hold your breath. And then we're going to start moving the shoulders forward, big forward movements. Keep breathing. The lymphatic system runs all the way from head to toe, so you've got to pump it right from where it starts all the way down. Okay, now we've got cervical rotation, so that just basically means you're rotating your head side to side. I'm going to encourage you to put your hands behind your back. Why? Because here it's going to force you to think about your posture. If you train here and you try to do this here, you're not going to get the movement and the circulation. You're not going to open anything up. So think about standing tall like a soldier and just get that head rotating. You'll also notice as soon as you correct your posture, you might actually have more rotation in the spine available. Then we're going to go side to side, just stretching out the side and pumping that lymphatic system right from the beginning where it starts. And then good morning. So here we just hinge forward and big arms. Inhale and again. And exhale. And again. Inhale. And exhale again. Inhale. And exhale again. Inhale. And exhale. Two more. Inhale. And exhale. Last one. Inhale. And exhale. So hopefully you start feeling some warmth going on. Next are the marches. So here you'll lie down. And here you're just going to lift up and you're going to squeeze the bum. And so now we're starting to pump the area of the pelvis. These are very, very important. Excellent at draining fluid. It's even going in a gravity opposing directions. So all that fluid is coming back to where it wants to be. You can do a single leg bridge if you're stronger. All of this stuff is really good. Just pump those hips out. And now you might even start feeling the bum warming up. And so those are the bridges. Once you've done the bridges, you come back and we go into our march. So now the march here, you just lift up here and the other side here. And then you march up. Now, if you have balance issues, something else that we cover off in our unit, I think it's 2 or 3 workshop where we work on legs, you can just hold on to the wall and just march those legs up. Make sure you exhale every time you squeeze those legs in towards your chest, compressing and allowing for that circulation to increase. Then we've got some squats. So here you're going to sit down and then back up. What I'm going to encourage you to do is have the chair nearby, because I find that many people squat very poorly, and it's also something else that we go over in one of the workshops. But I want you to reach back for your chair and then come up. Reach back for your chair and then come up so that you're going all the way down and up. If you feel like you're more athletic and you can go all the way into a deeper squat, feel free to perform the full squat. It's entirely up to you what you feel. So inhale and then exhale, up. Inhale, exhale, up. And there you have it. So that's a quick little morning routine that you can do to get your fluid moving, the lymphatic system going, and hopefully you feel warmed up. That's the ultimate goal. And I recommend that you try going through that circuit at least twice. If one might be sufficient for you. I mean, it depends on your level of activity and how comfortable you feel with it, but work up to 2. And that's it. And that's your management for lymphedema and improving circulation if you happen to be exposed to it. And it's also just great for movement. It's just great to get the body warmed up. All right. So sexual function or dysfunction will occur when any disruption to the nerves that supply the bladder, the penis, the blood vessels, the sphincters, anything in this area. If the nerves are damaged, then the function is going to become compromised. And when you're removing the bladder, along with the prostate, the seminal vesicles, the lymphatic system, and you're removing all of this tissue, you can already start to see all these yellow things or nerves coming off of the spine. And you can already see that when you cut and cauterize all of these areas, there's going to be some significant nerve damage. And so Neuropraxia is one of the conditions that occur following any type of prostate surgery or bladder cancer surgery. The nerves that innervate the penis are going to become compromised, and the vascular system is going to get shut down because the vessels are actually reliant on the nerves to dilate and to fill with blood. And so the erectile function it takes a really long time. So it can take anywhere from up to 2 to 4 years to recover this function, but it is extremely important to start early penile rehab. And the reason being is because if you leave the penis flaccid for too long, then signals get sent to the brain to deposit collagen, which then turns into scar tissue. And the longer the penis is left flaccid, the more scar tissue, and then the less likely that the penis will be able to fill sufficiently to have an erection that's sufficient for penetration. The men will lose upwards of 1,500 nocturnal erections each year as a result of this surgery. And those are the nighttime erections that men have to preserve the filling, and they'll have nighttime erections to preserve the filling of the penis to avoid this collagen deposition. The strategies for penile rehab, there are a couple here. The typical one are the PDE5 inhibitors, which are your Viagra, your Cialis, Levitra, those type of medications. They do require arousal, so a lot of men take these medications and then they wonder, well, it didn't work. Well, did you get aroused? No. Well, it's not going to work in the absence of arousal. So you need to combine both. Now, the difference between some of them too is that the Cialis is typically a low dose medication, and that is designed to preserve the filling phase. So the penis goes through various stages to become erect, and one of those phases is called the filling phase. And so that's what the Cialis low dose version does. It preserves the blood flow into the penis. But again, these things can cost upwards of like $300 to $350 a month if it's not covered under insurance. So it's a very expensive option. The other two options here, the intracavernosal injections, are what you see here, where basically you're taking an insulin needle and you're injecting the penis with a trimix solution. And it causes the vessels to dilate, and you have an erection that lasts about an hour to an hour and a half. If you over-inject, you can get something called a priapism, which is an erection that lasts longer than 4 hours, and that's a medical emergency. So be modest in terms of how much you increase your dosing if that is something that you are using. And the other one, which is one of my favorite ones, is the vacuum erection device. This one helps increase oxygen to the tissue and decreases cellular death. So what happens is you place this device here, which is what you see here. You place the ring at the base of the penis, and then you put the pump on top, and then you basically slide the pump up and down like this, and through negative pressure, the blood is drawn into the penis and the penis becomes erect. So this really helps prevent that scar tissue deposition that happens. It is also a strategy to lengthen the penis, because what will also start to happen is there'll be a loss of penile length, and you'll start to notice that the penis starts to retract closer and closer to the body. So this will help stretch that tissue out. While men are in the vacuum erection device, they are performing pelvic floor muscle exercises. And there's a way that we can apply more weight to the pelvic floor with this device on, and that allows for greater muscular growth. So it's really a win-win-win on all sides. I really do love this device, and I certainly coach my men on how best to utilize it for optimal recovery. So all in all, the pelvic floor muscle training is extremely important. It's a critical component to rehabilitation, not only for urinary incontinence, but also sexual function as well. And there has been some research, albeit rather small research, because there's not a whole lot of research out there in men's health altogether, but even less so in bladder cancer. And I think Alex has some stats as to how far behind bladder cancer is from prostate cancer. But nevertheless, there still is some research out there that suggests that preoperative training is important. So if you know you're going in for your NeoBladder surgery, then you'll want to make sure that you train your pelvic floor muscles prior to going in. It's just like any other surgical procedure, right? You want to get the muscles as strong as possible so that your outcome is significantly better. Post-operatively, after the catheter has been removed, and usually it stays in for about 3 weeks, that's when you'll resume your pelvic floor muscle exercises. And this is lifelong adherence. If you don't use it, you lose it. Just like any other muscle in the human body, if you don't train it, it's going to go away. So just because you gain continence doesn't mean you can stop. It means you need to go on a maintenance program to preserve the function of these muscles and continue to be continent. Now, there is some recommendations with regards to the intensity with which one should do the training, and they suggest doing it 3 times per day, looking at both the strength and the endurance, because the pelvic floor muscle is made of fast twitch and slow twitch muscle fibers, and they each have their own roles. For example, sexual function would be your fast twitch muscle fibers. Being able to prevent a cough, leaking with coughing or sneezing, those are your fast twitch muscle fibers. But going for a walk, for example, or doing things that require endurance, that would be your slow twitch muscle fibers. So they're considering both, and that's good, because that's what the research in prostate cancer also shows is much more significantly better when you use both and you address both. But their intensity is only 3 times a day. And it wasn't specified in terms of preferences for positioning, but I mean, I'm okay with this protocol, except if I'm trying to achieve the same results in my prostate cancer patients as I am trying to achieve in my bladder cancer patients, and I know that training the pelvic floor with a greater intensity results in faster recovery, then why would I use something that I don't think is as good as what's been researched in the prostate cancer world when I'm ultimately trying to do the same thing? So I employ this training protocol. I employ the one that requests that the male uses pelvic floor muscles 6 times per day, and that the exercise starts perhaps in lying and then sitting, then it moves into standing and more functional positions. If you just practice in lying or sitting, then you can't expect to be dry when you're standing or moving around, because you're not practicing for that event, right? So you've got to practice for the event that causes the incontinence. And same kind of concepts hold true. You're doing your slow twitch muscle fibers. So with the slow twitch, you're thinking about contracting the pelvic floor for 10 seconds and holding the pelvic floor and counting out loud, making sure that you're not holding your breath because you don't want to increase any more intra-abdominal pressure than you have to. And then letting it go really, really slowly. Not just letting go, because if you do that, you might actually have some leakage, right? So you want to just test it out, and you want to do it nice and slow and just make sure that you are successful at stopping the leaking. And then you repeat that 10 times. So that's your endurance piece. You can build up in terms of progression. You can add to this 10 seconds and build up to 30 seconds to a minute. And I even encourage men to try and hold a 20 to 30% contraction for an entire 30-minute walk. Okay, but the little baby steps, one step at a time. And then the other piece is the fast twitch muscle fibers. So here you're contracting the muscles at a rate of 1 per second. So you're going squeeze, release, squeeze, release, squeeze, release, squeeze, release, squeeze, release. And you do that 10 times. And because it's supposed to be done at a rate of 1 per second, you should have that done in 10 seconds. You repeat 3 sets, 10 seconds with double rest time, which then in this case would be 20 seconds. All right, so some take-home messages here. Technique matters. We Hegel, not Kegel, because we are not employing some of the strategies that we would use on women who have had children, for example, or who are suffering from prolapses. It's a completely different scenario. So we've got to make sure that we're using the front portion of the pelvic floor muscles and not the back. Intensity matters. You've got to train to fatigue. You've got to make sure that you are working these muscles to exhaustion. If you are trying to build up a muscle and you go and do a couple bicep curls in the morning, and then you go back and do a couple bicep curls in the afternoon and maybe 2 more in the evening, do you think your muscle is going to grow with that stimulus? No, it's not going to change. You need to train the muscle to failure until it's exhausted, and that's the stimulus that causes growth. And so the same thing holds true with the pelvic floor. When you're training, you want to make sure that the muscle, you feel like, okay, my muscles are fatigued. I had a good workout down there. Right? And then motion is lotion. So your cardiovascular fitness is going to be extremely important preoperatively as well as postoperatively. But the better health your heart is in, the faster your recovery and the better you're going to be able to circulate oxygen through the system. So you're going to heal significantly quicker with that. And also the effects of fatigue are well countered with cardiovascular fitness. You want to make sure that you're moving, you're using that lymphatic series that we just did together. You also want to be doing the GI tract or the constipation series that we're going to be learning in the Unit 1 workshop, as well as some core strengthening. Again, another piece of the puzzle that we're going to be learning in the Unit 1 workshop. So pelvic floor muscle training enhances strength and blood flow to the external sphincter, which can promote healing and recovery. And as I said before, 6 weeks before surgery would optimize your postoperative recovery. And unfortunately, it's not yet practiced in our healthcare systems to refer patients preoperatively. So I'm hoping that the information that I've given you here tonight will allow you to now perhaps educate someone else who may be going through this journey. And hopefully we can all together start spreading the word. I thank you so much for your attention. Don't forget to register for the workshops, and I am happy to entertain any questions that you may have at this time.
Thank you very much, Christina. That was awesome. If you have any questions for Christina, please go ahead and unmute your line.
Hi, Christina. It's Susan. I'm all the way from Calgary, Alberta. I got invited by
Alex.
Hello. I just had a question like this. I know your training is basically in male pelvic floor therapy, but I just want clarification. Would this, the way you presented it tonight, would this be predominantly okay for women as well? They're undergoing the same surgery? Yeah.
Yeah, yeah. So women, sorry, and I know, I guess I didn't realize that there were going to be women at the presentation as well. I'm just so used to working with prostate cancer that obviously I don't deal with women who are going through this, and I think I could have looked into a little bit more of the female side of things for this, but certainly if they have had the NeoBladder, then these pelvic floor muscle exercises are going to hold true for them as well, and the intensity with which they do it. So this is something, I mean, at the end of the day, if you want to make your muscles stronger, you've got to really work them, right? And the difference though with men is that they're now 100% reliant on that muscle, so they've really got to work it.
Okay.
Right. So it's slightly different, but usually I start my women with 3. And if we don't get the results we want, then I say, okay, you know what, let's bump it up and see how that goes. And there's so many different variables. Every person's going to be different. And sometimes it can be, you just got to find what works for that person and how that pelvic floor muscle fires. A lot of times throwing somebody off balance, putting them on one leg and then monitoring how their pelvic floor works, all of a sudden the pelvic floor just wakes up because it's a stabilizing muscle. Whereas when they're on 2 feet, it doesn't seem to work as much. So these are things that I've learned over time, and it never ceases to amaze me, right? But it's always individualized from one person to the next. So if your balance is poor and you find that you're not having strength in your pelvic floor, maybe work on your balance. Because as soon as you go on one leg, the pelvic floor has to fire. That's its job, is to stabilize the pelvis. That's one of its jobs, right? It's got 5 main functions, but one of its roles is to stabilize the pelvis. So if you force it to work, then that's even better. And that's why one of my workshops is hugely focused on balance, right? In terms of lower extremity. So yeah. And I know I apologize for that. I wish I don't know if I didn't realize there were going to be so many women here this evening.
Yeah, sorry, I should have been more clear about that. We do have a mixed audience, male and female.
Now, Susan, can I ask a personal question, or would you rather not?
Yeah, sure.
Can I ask, or have you had bladder cancer as well, or?
Yeah, I'm a 2-time survivor, but I did not have to have my bladder removed. I was diagnosed early stage. But
okay.
that being said, I have had other abdominal surgeries, and so I am basically okay. But I'm interested in this topic not only for myself, but I used to have an active support group here in Calgary, but unfortunately it fell apart.
Okay.
But I'm just wanting to have the knowledge, because occasionally I do still do phone support. I get calls from Bladder Cancer Canada in Toronto, and I have had, on occasion, I have had, recently I just had one lady call me. Thankfully, she did not have to have her bladder removed, but because of the stage and grade of the cancer, she was right on the fence of going either way. But so I would love to be able to pass this kind of information on to women that say, hey, I would not know who to contact in Calgary, but at least be able to say, call your doctor, see if you can get information like this, because this blew me out of the water tonight. Like they're just, because women, like a lot of women that have RCs, I don't know about Zena, but some women have already had hysterectomies because they've had other health issues. Sometimes I've come across with women, they have to have the whole shebang done at one shot. And because the uterus is a bigger organ, and if you're having that removed, and usually they'll remove everything, the ovaries, fallopian tubes, they'll remove the uterus, they'll remove sometimes part of the vagina, and all the lymph nodes. So for us, it's in some ways it's a big deal for the guys. I'm not going to negate that, but it's a big deal for the women too, because we have all the physical healing, but we also sometimes end up in surgical menopause for the women that are younger that have to go this route. So it's a hormonal thing for us as well as the physical. But when you mentioned some of the pelvic stuff tonight, I'm thinking, I was just blown out of the water. I could have used this after my hysterectomy.
So that's the other huge population.
Nobody recommended it, not even my surgeon. I mean, she did a great job. I was having other issues down there, and she fixed everything, but I'm starting to have a little bit of, little bit here and there. So, but anyway, I'm just thinking like this. Oh, this is a miracle.
That's great.
Yeah.
So you had your you had a hysterectomy?
On that, yeah, but I had that in 2002. I had a fibroid and surgery.
Oh, so that was completely separate.
Completely separate. And now with women with bladder cancer, sometimes some women are in my position where they might have had the surgery previous, and if they have not, when they have their bladder removed, doctors will very often recommend removing the uterus and all the reproductive organs because they're resting right next to each other.
Right.
And you know, if the tumors have possibly gone through the bladder wall, they may or may not be in the uterus. So that's the reason for it. You know, so but
that is my understanding as well. I did have my bladder removed, and at the time, Dr. Shagan, I mentioned that it's standard, or the gold standard is to remove all of the reproductive organs as well, because of the proximity to the bladder. And yes, all of this pelvic floor information would have been so much handy more than 10 years ago.
Yeah.
It's still so infantile in its awareness, right? And it's taking a long time to get out there, and I'm doing the best that I can do in terms of trying to collaborate with doctors and do these presentations, because it's really, you know, it's shown time after time, year after year in the highest level of medical evidence that we have to date, that pelvic floor physiotherapy should be the first line of defense for any kind of you know, pelvic floor dysfunction before drugs and surgery, right? And it's yet still not employed that way.
Is erectile dysfunction the same? Do they get the same impact from a bladder removal that you get from a
prostatectomy?
Prostatectomy.
Yeah, it's similar, but obviously significantly more nerves have been compromised, and so restoring that function is a little bit more challenging. Nerves just take a really long time to grow back. They grow at about a rate of 1 millimeter per month, so it's like watching paint dry. Yeah, and the more extensive the damage, the longer it takes.
Any last minute questions, guys? Okay, great. Thank you so much.
Thank you,
Thank
Christina.
you.
It was awesome.
Bye.
You're welcome. See you guys again. Bye.
Bye-bye.
Thank you very much, Christina.
You're most welcome.